All right, welcome back everyone to another virtual shadowing session at Hearts for Health. Today we're joined by Nicole, who is the Assistant Program Director at the PA Residency Program at Johns Hopkins for Emergency Medicine. I have a few reminders to those who are joining in, especially if you are new to virtual shadowing, if this might be one of your first sessions here. Towards the end of each of these sessions, we have a Q&A. So if you have any questions for Nicole, feel free to type them out. And at the very end of this session today, it'll be going to around 8:30 Central. We will have that Q&A, and I'm going to read through the questions. Hopefully, we'll be able to get through them all. Also, if you want to stay updated with future shadowing sessions, either you can follow us on Instagram or join our listserv. Just keep track of the time zones. We start at 7 p.m. Central, but if you're on the East Coast, it's going to be 8 p.m. If you're on the West Coast, that would be 5 p.m. So just keep track of the time zones. We usually operate on a Monday and Thursday schedule. So that's usually when to expect sessions. But because they are with new speakers, with new specialties, we have physicians, we have PAs, we have nurse practitioners, we have dentists, we have a whole host of speakers for everyone in the pre-health field. It's always great to stay tuned with who is going to be next. And like I said, following us on Instagram or joining our listserv are two great ways to do that. We post our flyers there and we post other program announcements too. If you want to join our listserv, you can either do that by subscribing at the bottom of one of our web pages where we have a subscription form. Just enter your name, your email, and go ahead and submit it. Or you can directly email us at shadowing.h4h@gmail.com. That's the number 4, h@gmail.com. And just ask to be added to the listserv again with your name and your preferred email contact. We recommend a personal email because sometimes school emails filter things out. But with those reminders out of the way, I'm going to pass it on to Nicole. If you guys have any questions for us about virtual shadowing or Hearts for Health in general, feel free to reach out over email. But I don't want to take too much time. So Nicole, feel free to take it away.
Thank you, Michael. And thank you guys for this opportunity to share. So my name is Nicole Heidenreich, and I'm going to tell you about a day, or rather a night in the life of an emergency medicine PA. So as Michael said, this is me. I've been a PA for about 10 years. I started my career out in neurosurgery and for 3 years, and then decided I wanted to transition to emergency medicine and wanted to become proficient, fastest way possible to be able to operate at the top of my license. So for that reason, I did it through an emergency medicine PA residency program. I now am an assistant program director of that residency program where I graduated, and I stayed on at Johns Hopkins Bayview after graduating. I also help educate the new PAs and NPs who come on staff who don't choose the residency pathway, and I'm the onboarding coordinator for them. Everybody's path to medicine is a little bit different. I grew up living overseas with my family, who was actually like Christian missionaries. So I had a really atypical upbringing, and my interest for medicine wasn't really peaked until really early college, and I grew up with some maybe more gender roles than some other people, and I think I had personally never thought that I would be somebody who would go to graduate school or even go to medical school. And so I quite frankly didn't even know that I was really interested in science. I thought that I was interested in history and international relations. So it was kind of a journey for me to discover that I really like science and found the medical field fascinating. You know, people are always going to ask, do you wish you would have gone to medical school? What's the difference? For me, when I was that age, medical school didn't even feel like an option because of just my background. So I started to get interested in medicine, started taking science classes, really was like, oh, I'm really good at this and I like this, which led me to be interested in medicine. And at that time in my life, going to medical school just seemed like way too much time. So I was happy to discover the PA profession and ended up going that path, and I've been very happy with it. So this is like kind of the stuff I'm going to talk about today. I think I've introduced myself. We're going to talk a little bit about the PA profession and training, the structure of my emergency department, because it's the only one I've worked in, and then the PA's role, my PA residency. And then most of the time we'll talk about a day in the life. We'll talk about some cases and try to give you a sense of what it's like in the play-by-play of first couple hours on a shift. So here we go. All right, so this may be redundant for some, but so we can sort of skim over it. But the PA profession has been around since 1967. It was kind of born out of a need for primary care providers. It was born out of, and then expanded when residency work hour restrictions left a lot of hospitals void of workforce. And also it ended up really kind of starting mostly it didn't start in the military, but the military was like one of the first adopters of the profession, as a bunch of people were coming home from Vietnam who were highly trained medics in the military, but yet did not have a civilian equivalent to their career. So the PA profession, we're licensed to practice medicine under the supervision of an attending physician. And that supervision can mean a lot of different things. It can mean direct, indirect supervision. And as you become more and more senior and more experienced, and you have more the trust of the people that are supervising you, it becomes much more collaborative. So early in your career, early in a specialty, you will need much more direct supervision than you will later on in your career or as you become an expertise in something. Work in every area of medicine. There's a lot of us. Education is you have to have a bachelor's degree, and then the master's program is 24 to 28 months. And it's like straight through kind of like medical school, and it's modeled after medical school in that the first year is like the first 2 years of didactics for medical school, and then the second year is like the second 2 years of clinicals. Obviously they cut some things out, but and we can talk more about that later, but that is the model. So when you graduate PA school, you take a test, you get certified, and you're actually licensed to practice. You write prescriptions, you can see patients, so long as you are being supervised in some form or another by a supervising physician. Now, you guys know, like, you come out of medical school as an intern, and that would seem really scary to be a doctor in a hospital taking care of patients. So it is not required for PAs to do a residency. And they're becoming more popular, but the traditional model has been on the job learning. So the old model used to be that, like, you'd have one doctor and he would have a PA. So you'd be Dr. So-and-so's PA, right? Now the system has changed a whole lot. So I work in an ER and I will have a different supervising attending every day, and I might not work with one every couple of months. And so that varies from job to job. But in any case, your first couple of years out of PA school, you hopefully have a mentorship situation where you're mentored by other PAs, and you have growing levels of responsibility as you go through your career. The formal postgraduate programs is like one that I help run at Johns Hopkins Bayview that basically tries to model like the first year and a half of physician residency, sends people on off-service rotations, gives them a lot more didactic and simulation experience. And we have 6 residents at a time. And our goal is that at the end of the residency that you would be able to take care of almost anything that walks in the door without the need for intense supervision. So it was a really great decision for me. I really liked it. It was a way to kind of jumpstart my career. And it's been really gratifying to be able to teach other people as well. There are certain specialties where PA residencies, some people call them fellowships, PA postgraduate training programs, are are more popular or maybe more useful. I know emergency medicine, critical care, and surgery have a lot of programs, and a lot of times that's because those are specialties that we don't necessarily cover like as in-depthly in PA school. All right. So I work at Johns Hopkins Bayview, which is the this is in the middle is the big Johns Hopkins Hospital, and then to the left and right are pictures of Johns Hopkins Bayview. We're a 420 bed academic medical center. We used to be a community hospital a long time ago until Hopkins took them in the fold. We have all the same staff, attending staff, the residents from the main downtown Hopkins rotate at both hospitals. And so it's just, I like it. It's a little bit more of a community hospital feel, also being an academic institution. And I worked there for 7 years. So, all right, let me tell you about my department. So we have something we call the main side, and that's kind of like vernacular for like where the sicker patients go. And that has about 39 beds, plus or minus some hallway beds. And it's staffed by 2 or 3 attendings with 4 to 5 APPs. And when I say APPs, that means PA or nurse practitioner, or physician resident, or PA resident. So those are non-attending providers. And so the attending to either APP or resident ratio is about 1 to 2 or 1 to 3. The nurse to patient ratio is about 1 to 3 or 1 to 4. When you're on the main side, you will, you will discuss all of your patients with the attending. And you run your plans by them. They will see the patients. And like I said, obviously earlier in your career, that discussion is going to be much longer. They're going to be checking a lot more of your work. And as time goes on and they understand your scope and your abilities, there's less intense supervision needed. But you know, when the patient comes in, like the PA or the physician resident or the PA resident is the person who sees the patient, does most of the doctoring, and then unless the patient's acutely unstable, the attending might not get involved till a little bit later, till things are starting to kind of come back. We're starting to talk about what's really going on with this patient. Obviously, they're always there and always available should you need them sooner than that. The minor care area is usually 4 to 6 beds. It's staffed by 1 PA or nurse practitioner. And those patients are not all individually discussed with the attending. They tend to be lower acuity patients, although the physician is available for consultation if needed. And then in triage, I don't know if you guys have heard, but ED boarding and crowding is a huge issue in this country. And so it's really important that we are able to sort of screen patients and have a provider in triage to be able to pick out who's sick, who's not sick, get orders going, decide who needs to go back first, reverse triage, et cetera. So we have 1 or 2 APPs who do that shift. All right, so it's Monday night, you're coming on, and we usually work 12-hour shifts. So most people work 3 12-hour shifts a week. I have some administrative and educational responsibilities, so I actually only work 2 shifts a week. But I use that other time for administration and education. So you will work, if you're a regular rotating schedule, you will have 3 shifts a week. You'll probably have 3 or 4 every month that are night shifts. And we try to do them in a row, and you'll work 1 or 2 weekends a month. The good thing about the schedule is that you can kind of try to stack your shifts, and you can take time off, right? You could work 3 days, you could work 6 days and have a week off if you can time it right. So that's a lot of things, like a lot of people that work in the emergency department are able to, if they can game the schedule right, travel a lot and have a very different but good work-life balance. Okay, so anyway, it's Monday night. Monday night's the busiest night in the ER. And you come in at 7 and you get sign out. I'm going to make this a little simpler than real life, because in real life, I probably would get 10 patients, but we're going to say it's 5. Okay. So you get told, okay, hey, Nicole, so room 1 is this 55-year-old guy. He's got some chest pain. Basically, the normal tests that we do, which includes like a troponin, which is a cardiac enzyme that we check to see if it's elevated. That happens when cardiac ischemia is going on. That's been normal. His chest x-ray was normal. Her chest x-ray was normal, and the EKG was okay. But she's still moderate risk chest pain. So we're bringing her into the hospital, and we're waiting for medicine bed to open up. She's stable, but the nurse just told me she was having back pain and she wants her home oxycodone written for her. Okay, I have no questions. So we moved on to the next one. Okay, sorry, Nicole, this one just came in. The EMS just wrote in, the patient has low blood pressure, looks kind of sick. I would probably go see them next. I'm sorry I didn't have time to see them. I told the nurse to hang a liter of fluid. The next one, this is a 49-year-old homeless female. She is here with alcohol withdrawal. She wants to go to detox. As is usual, she's at risk of seizures. She's having some shakes. She's on a protocol, so the nurses can give her benzodiazepines or Valium, Ativan, which will help to abate her withdrawal symptoms and hopefully prevent her from going into alcohol withdrawal any further. But I would go check on her because I just had to give her a lot of Valium. She's still pretty shaky. I'm not sure the protocol is enough for her. Okay, room 4 is a Spanish-speaking female. She is 6 weeks pregnant. She's having vaginal bleeding. I just saw the ultrasound, and looks like she's probably having a miscarriage. I haven't gotten to talk to the patient yet about it. And you look up and the husband is staring at you as you're signing out, waiting for you to talk to them. All right, and then the next one's a 62-year-old female with high glucose, a urinary tract infection, new onset high blood pressure. She's never seen a doctor before. She's been having some symptoms of hyperglycemia. She's probably new diagnosis of diabetes. I gave her some IV fluid. I gave her some low-dose insulin. You have to see how it shakes out. I'm hoping we can, set her up for discharge and maybe prescribe her metformin, which is an oral medication for diabetes, but we need to talk to case management about whether or not they can sign her up for follow, because I'm not sure if she has health insurance. All right, so we have choices here, right? Where do you go first? All right, who's going to die first? And who is going to take the most time? So big part of the ER is constantly doing these calculations in your head about how you spend your time and how you prioritize things. You're going to make hundreds of decisions this shift, and here's your first one. So who do you go to first? Thought this was going to be an interactive session, but now I'm just staring at a computer talking. So one would say, Nicole, this poor woman in room 4 is having a miscarriage. She doesn't know what's going on. Her husband really wants to know. They're very upset. You should go and see them first. Should I? He's staring at me from the doorway. I feel really bad. It's really scary having a miscarriage. Okay, Nicole, no. Bed 1 is being really demanding. She's now standing in the room and she's saying, I want my home pain medications. Somebody give me my oxycodone. Do you go see her first? The patient in room 3, you were told that they might need some more medication for their alcohol withdrawal. You look at the monitor that's sitting next to you and you see their heart rate's a little high. They're probably stable. Can you just trust the nurse to come get you if she needs you? The one in room 5, she sounds pretty stable. I do need to kind of get her out of the ER though, because there's 45 patients in the waiting room. And if she's an easy discharge, then I don't know who else is sicker in the waiting room that needs her bed. So I don't want to wait too long if she's ready for discharge. Oh, then there's room 2. And this guy has low blood pressure and they said he looks like crap. So you go and see room 2. So this is a 75-year-old female with a history of chronic heart failure. And I don't know what stage of education you guys are in, so I will kind of try to explain stuff a little bit in more detail, but maybe Michael, you can text me and tell me if this is too dumbed down or too
Yeah, we actually got
advanced.
we got a few responses over the chat saying that room 2 was the one to go to first.
Good.
So people were hit that nail on the head. And the majority of the students listening in here are in their undergrad right now in college.
Okay. So people have taken anatomy and physiology?
Some have, some might be freshmen who haven't
Okay.
had that yet.
Okay. So this person has chronic heart failure. The heart doesn't squeeze as well as it should. And this is a very common problem for older people. They have high blood pressure, diabetes, they've had bilateral hip replacements, and they're coming from home. You're lucky enough that the EMS providers are still there unloading the patient, and they tell you some history, because sometimes it's tough to get history from older patients who are maybe confused, who are very sick and don't exactly know what's going on. So EMS says the family came to visit. She lives alone. They hadn't seen her in a couple of days, but that wasn't totally out of the ordinary. And she just seemed really lethargic, weak. She almost fell when they were like trying to walk her. She usually goes to the grocery store and she's independent. This isn't like her. They loaded that her blood pressure was 80 over 60. Now it's supposed to be greater than 120 over 80, right? So her heart rate was 120. That's high. So they gave her 500 cc's of normal saline, which is IV fluids. Patient says they don't feel well. So this is how we approach patients in medicine. We do a history and physical exam. I divide this into the history and physical, the data gathering, investigation phase. And then you take all that information and you do an assessment and you plan. So you identify what the problem is, figure out what you think's going on, and then do something about it. So we're going to start with the information gathering phase. And I will say this is the way it typically works in medicine. In the ER, it gets a little different. So this is your history that you get. We talked about it. There's a list of medications that she's on. Most of them are for high blood pressure, for diabetes. She has an inhaler. She's a smoker. She probably has, she does have COPD. Okay. All right. Spiriva. Okay. That's for COPD. Lasix. That's for heart failure. Spironolactone. That's for heart failure. Okay. This all kind of makes sense, right? And there's this PQRST thing that you'll learn where if somebody has pain, you try to figure out their provoking factors, the quantity, the region, the radiation severity. What's the situation that surrounds this problem that they have? When did it start? Has it happened before? Is there any thing that happened to them recently that would have caused this? So we're fast forwarding a little bit, and in the ER, you often don't have time to get as detailed of a history that you would like, right? And so you don't have time, or the patient doesn't know them. You have to go and sort of sometimes investigate, look in the chart and find people have a really hard time keeping track of their medical stuff. They often are not reliable. And especially if they're ill and confused, like this little lady. So you do your physical exam, blood pressure's low, heart rate's high, temperature's high, her respiratory rate's a little high at 22. She's kind of out of it. She sort of wakes up when you shake her. She opens her eyes. She says, "Leave me alone." She closes her eyes again. She's oriented to self and place, but not to time. Her head doesn't show any signs of trauma. Her tongue seems a little dry. Her pupils are equal. Her face is grossly symmetric. She's breathing a little fast, but it doesn't strike you as being in overt respiratory distress. Her lungs sound clear, except for she has some scant expiratory wheezes. Her heart is regular rate. Well, it's not really regular rate. It's tachycardic. You don't hear any murmurs. Her belly is non-tender. Her extremities are warm. Her pulses are kind of faint. So, now you, ideally, in an ideal world, you'd have all this information. You'd talk to her family. You'd look in the chart. You'd get a bunch of different tests. And then you would look at everything and decide what's going on. So you think, okay, I'm going to go sit at my computer. I'm going to think about all of this. And I'm going to come up with a differential diagnosis, a list of things this person could have. And then I'm going to be freaking Dr. House and I'm going to crack this case and I'm going to figure this out. Well, guess what? That all takes time. And in the meantime, you have the nurse who comes, Nicole, what the heck are you doing? Sitting down at your desk. This patient's hypotensive. I just checked their blood pressure again. It's even lower. And you realize you don't have time to be an investigator. Sometimes in the emergency department, you first have to be a firefighter. You have to put the fires out before you can go sit back and think about everything. So this brings us to one of my points on emergency medicine. You have to be adaptable and we have to make decisions with incomplete information or bad things will happen. If you freeze up and you're unable to make decisions with limited information, the patient could die. Sometimes you get to be Dr. House. I hope you all get this reference. I hope this is like not too old of a television show, but sometimes you get to be Dr. House and you get to make some really great diagnosis. But sometimes you really just need to put out the fires and maybe somebody else gets to be Dr. House. So maybe the patient comes in super sick. You make sure they don't die. You get a couple ideas going about what might be going on, but you might not be the person to come up with what exactly is going on and what is the correct treatment for it. And that's something that some people don't like about emergency medicine. There is sometimes a lack of closure, you know. We don't always know what happens to all of our patients, and other people like it. And they're just different roles that you have in medicine. But when you're in the emergency room, it's very unlike being on the inside of the hospital on the hospitalist service. It's very different than anybody other service that works in the hospital. You're the front door. You see all of the information unfiltered. You see the first presentation. You don't, I mean, sometimes people come from their primary care doctor and they say, hey, this guy, he's got this, I'm worried about this. Most of the time you don't have that introduction. You kind of are starting from scratch. And some people, like me, really like that. Okay, so, all right, Nicole, fire's got to be put out. What am I thinking? I can't go back to my desk yet. Okay, all right, yes, what am I thinking? Okay, could you give her a liter of normal saline? Could you call the chest x-ray tech, have them do a chest x-ray on her? Could you get an EKG? Could you draw some labs? I want a CBC, I want her electrolytes, liver panel, kidney function, I want a lactic acid, and I want blood cultures because she has a fever and I think she has an infection. And you know what? She looks sick. Just get her 2 good IVs and just put her on nasal cannula, 2 liters, so that I can have time to take a deep breath and figure out what's going on. Okay. I have a good nurse. She's like, okay, Nicole, got it. We'll do. And I say, tell me if her blood pressure falls any farther. And let's cycle it every 15 minutes. Okay. Close loop communication. She's like, got it. Sounds good. And we divide and conquer. Okay. I go back to the computer and I start thinking, what is going on with this person? So differential diagnosis is a list of possibilities that you think your patient could have. And we try to start with a long list and then pare it down and start cross things off. The idea is you start with a long list so that you don't forget anything. All right. You don't have early closure. You don't jump to conclusions. You come up with a long list, think of all the bad things and all the possible things. And in the ER, we're going to like focus on the bad stuff, right? And then we're going to think about each one of those things. We're going to order tests that help either rule in or rule out those diagnoses. Or we're going to do additional physical exam findings that help us rule in or rule out those different differential diagnoses. Or we're going to do different history or something that helps us rule in and out those things. So what do we got to figure out first, though? What are our problems? Let's put words to it. Let's make them problems. Okay, she has low blood pressure, right? We got to figure this out. She does have a fever. Interesting. Need to figure that out also. She's a little lethargic too. I kind of think that's because of the first 2, but all right, we'll come back to that third one. Okay, so let's start with the low blood pressure. Why do people get low blood pressure? So people get low blood pressure for a multitude of reasons, okay? One of them is dehydration, right? It's pretty easy to imagine. You throw up a bunch, you poop a bunch, you bleed, from something, you have less blood volume. Okay, we'll buy it. Is she having nausea, vomiting, or diarrhea? I don't think so. We could ask her family. She's denying it. EMS didn't say anything about it. You can prescribe somebody too much blood pressure medicine, or they could be taking it inappropriately. Sometimes, in my opinion, outpatient providers are a little too aggressive with blood pressure medications, right? And you have people with autonomic instability who are little old ladies and they're on way too many blood pressure medications. So sometimes that's the cause of it. People have orthostatic hypotension. It's extremely common. I mean, have you ever stood up too fast when you've had a couple beers? You're not terribly dehydrated. You don't need to be in the hospital, but all the blood rushes from your head down. So as people get older, that reflex that tells your body, hey, we're standing up now, you need to make your heart rate faster to make sure blood goes up to your head, that reflex gets dampened. And so people will get dizzy almost every time they stand up sometimes, you know, and every once in a while they'll pass out. Okay, we know what that's from. Then there's shock. So what is shock? It's shocking, right? Shock is when you have hypotension and end organ damage. Okay, you can have low blood pressure and it can make you feel bad. You can have low blood pressure and you don't notice it. But there's a difference between having low blood pressure and having such low blood pressure that it's affecting how much blood is getting to your organs. So we have to figure out if our patient's in shock or they just have a low blood pressure. So you have a failure of either the pumps or the pipes. Sorry, the pump or the pipes. I really like this analogy. Shows the person at the gas station. The heart is the pump, the gas pump. The vasculature is the tube there. And the tissues and organs are the car. So if your heart's not working, you have pump failure. If there's something blocked in the tube, you can have not enough perfusion to whatever's at the other end, wherever that tube is going to. If you don't have enough volume in the tube, you don't get enough volume in the car. So shock leads to, I don't know why it should have like boxes. This is supposed to be an arrow, but first it's reversible and reversible damage, right? There's a point at which there's reversible damage. If you restore blood flow at a higher velocity, like to this organ, they will be able to get over the fact that they haven't been very well perfused for a couple hours, okay? But at a certain point, there starts to be tissue death, right? When things don't get blood, they die. So not the whole patient necessarily dies, but little parts of their kidneys start to die. They have like microvascular ischemia, and that stuff adds up and can produce multi-organ failure, and untreated, that leads to death. So how do we tell if somebody has shock? People will say, oh, well, they don't look like they're in shock. Okay, well, you got to give me something more than that, right? Certainly there are, there's the physical exam features, right? Cold extremities, you can't feel their pulses. Confusion, that indicates maybe there's not enough blood going to their brain. They're having chest pain or shortness of breath. Those things can indicate end organ damage. Other labs that can help you figure out if you're having poor perfusion to your organs is your lactic acid. So your lactic acid gets cleared by your liver when you don't have enough either blood flow to your liver, it doesn't clear it very well, or when you have some ischemia, or when you have anaerobic respiration of, I'm going back here, I'm really going back to biology 201. But if you're not getting enough oxygen, your cells are not able to use their aerobic metabolism, so they have to go anaerobic, which is less efficient, which is the backup plan, right? And it produces lactic acid. So it's a sign that your body is using this backup plan that is less efficient, and this is a byproduct of it. Okay. Other things that can get elevated when your kidneys don't get enough perfusion. When we say perfusion, we mean blood flow. They start to leak creatinine. So they're not clearing the creatinine, so it's staying in your body. So that creatinine will go up. So these are things that we look at to try to figure out, is this patient in shock? Here's a way that we sort of define and think about sepsis, which we'll talk about in a second, as well as something called SIRS and shock. So SIRS criteria is systemic inflammatory response syndrome. So if you have two or more of the following, meaning a heart rate greater than 100, a temperature greater than 38 Fahrenheit, respiratory rate greater than 20, or white blood cells greater than 12,000, or with greater than 10% of them being bands, which are very like immature white blood cells. And it's a sign that the body is like, all right, we got to go. We got to pump out these little baby white blood cells because we got a big job to do. There's a big infection going on here. So those are signs that your body is fighting something. Now, SIRS is a red flag to you. It's saying like, this is not okay. There's something going on here. This person is sick. They might have sepsis. So if you have SIRS plus a suspected source of infection, urinary tract infection, pneumonia, appendicitis, you have that systemic inflammatory response with a suspicion of an infection, then we call that sepsis. If you have sepsis with a lactic acidosis, an elevated lactic acid, or a SBP, which is systolic blood pressure less than 90, then you have severe sepsis. That's when we start to think that you're starting to get this more end organ damage, going in the wrong direction because your blood pressure's falling. And we'll explain why that happens. Meaning your body was fighting, and now it's losing. Now you don't have enough blood volume in there that your pressures are starting to drop. Severe sepsis is when you have hypotension or low blood pressure despite adequate fluid resuscitation. And then we define that as septic shock. So does our patient have shock? Maybe. What does the chat think?
So far, we're waiting on responses to roll in from there.
All right, I just need to drink some water. Okay, so yeah, like I don't know, I'm worried this patient has shock because they have confusion, they have this temperature, they have an elevated heart rate, and they have low blood pressure. So they might even have severe sepsis. So how are we going to find this out? Okay, so we've sent the labs. And then we see that these are the sort of things we're thinking about. So the creatinine comes back and it's 2.5, which is pretty high. The patient doesn't have chronic kidney disease because you're a good provider and you looked in the system and their creatinine 2 months ago is normal. So you have to assume that's a new elevation in their creatinine. The white blood cell count's high. The urine has a bunch of white blood cells in it, has leukocyte esterase, and has nitrates. So combine that with their fever, their low blood pressure, their high heart rate. Well, they probably at least have the severe sepsis. So I think they're in shock. Now, we're going to talk about different types of shock, right? This patient looks like they have septic shock because they have the fever, right? They have the fever, they have a suspicion of an infection. But whenever I have somebody with low blood pressure, I try to remember that there's other types of shock, trying to practice what I preach, make a big long list of all the bad things that could be going on, and think about, am I sure that it's this one? So these are the 4 different categories of shock. So hypovolemic shock is on the far left side. And that is a reduction in the intravascular volume. Therefore, it reduces your cardiac output. You don't have as much blood to carry the oxygen to the tissues and where it needs to go. So that can be hemorrhagic shock, right? It can be from burns, where you have a lot of surface area of your body that's burned and you leak out a lot of fluid. GI losses, like we talked about earlier, nausea, vomiting, diarrhea. And we won't touch on the others because they're a little more complicated. So cardiogenic shock is when the pump is not working. So if you think about somebody who has chronic heart failure, where over a long period of time, their ejection fraction is supposed to be like 55%, is now like 25%. They're not able to compensate, right? Maybe there's something else happens to their heart. Maybe when you have a heart that has CHF, they're extremely pressure dependent, volume dependent. So when they're on the perfect amount of medications, the perfect amount of Lasix to make them pee out the amount, the perfect amount of beta blockers to keep their heart rate just like where the cardiologist wants it to be, when they're on, this changes, right? Like the human body is like dynamic, right? Something gets off with the volume status, they miss a medication dose, they get a little heart attack maybe. Part of their muscle gets weaker, their heart muscle gets weaker than it used to be because they have a small heart attack. So all of a sudden they were walking around with an ejection fraction of 40%, but now it's 20, right? They have pump failure. So if you don't have, the pump is not working, you're not gonna have blood pressure on the other end of that pump. So this can happen when somebody has an acute MI, like a big heart attack, right? Like you cut off your LAD, your whole big wall of your heart now no longer is like squeezing and it's just sitting there flapping. And the rest of the heart is like trying to get the pump moving. It gets tired, get backup of fluid. It can't pump forward. You can have arrhythmias that your heart can go into an abnormal heart rhythm where the heart is just like fibrillating or beating abnormally, and it's not actually moving blood out where it needs to go. It's not effectively pumping. And then if you have like an aortic valve or a mitral valve that kind of acutely ruptures, you're another reason why your heart structurally is not able to work. All right, obstructive shock is a little bit more uncommon, but this is from like an obstruction of the outflow of the blood leaving the heart. So this can happen if you think about, if you get a big pulmonary embolism. So you think about blood comes in the right side of the heart, goes out into the pulmonary arteries to go to the lungs, where then it gets exchanged and comes back to the left side of the heart. Well, what if you get a clot in the pulmonary arteries? The heart is trying really hard. It's trying to push through that clot and it's trying to get the blood out, but there is a clot in the system. The other thing that can happen is you can get a tension pneumothorax, which is an air pocket that basically is between the layers of your pleura in your chest, and it starts to suck in with fluid. This can happen like when you have a trauma to your chest wall, suck in, and then it's starting to push with this huge pocket of air the structures of your heart and your great vessels over to one side, and it's getting like cut off. There's not enough, there's too much pressure that's creating tension and the blood can't go where it needs to go. Sorry. Pericardial tamponades, another one. It's where you have, you get sort of a collection of fluid around the heart and the sac that holds the heart, where that fluid collection can get so big that it prevents the heart from adequately squeezing. All right, we finally made it to distributive shock. So distributive shock is what sepsis is. So sepsis is oftentimes really thought of like hypovolemic shock, right? I've been talking about how there's not enough stuff in the pump. Not enough fluid in the veins or in the pipes. But really, actually, what happens is that I like this picture over here. So you get all this bacteria, all this inflammation, and you get leaky capillaries. So it causes like all of this nasty inflammation in the tiny blood vessels. And if you see, I don't know if you can see it well, but basically like fluid starts leaking out into places that it's not supposed to be. So so they'll say like people with distributive shock will have warm extremities. People with cardiogenic shock, they say, will have cold extremities because you have a lot of vasodilatation distally and you have all this leaky vessels, but you don't want it that way. It leaves, there's less fluid in the pipes because it's leaking out. So this can happen with anaphylaxis as well. So anaphylaxis is an allergic reaction. It can cause, like, a severe anaphylaxis can cause like a massive vasodilatation in your whole body. And so if somebody goes into anaphylactic shock, people overuse that term, but what it really means is that you have hypotension and end organ dysfunction because of an allergic reaction. The treatment for that is epinephrine. And so the neurogenic shock's a little bit more complicated. We won't go into that. So those are all the types of shock. So I think our patient probably has septic shock, right? Because they have a fever, they have a source. That's kind of where I'm leading. Now, do I know anything about their heart? Do they have a bad heart? Oh, they do have a bad heart, right? So do they have cardiogenic shock? God, that would be extremely unlucky for them to get two different types of shock, right? Or it would be extremely unlucky for them to have a UTI and a fever, but they don't have shock from that, but they have shock from their heart. So I'm not going to spend a ton of time on it, right? But I'm going to get a chest x-ray and I'm going to see, is that heart huge? Is there a bunch of fluid in their lungs? Because if there is, then okay, I mean, we need to consider this, right? Because when people go into cardiogenic shock, the fluid has nowhere to go. They can't move it forward. So it fills up their lungs and it makes their lungs a fluffy on x-ray. So maybe I see that, and then I grab my ultrasound and I take a look myself and I see how their heart's squeezing. Okay, I think that's reasonable. Not a ton of work. I want to check that off my list. So I get a chest x-ray. Chest x-ray is clear. Okay. All right. I feel better about this just being sepsis. Okay. Do they have hypovolemic shock? Are they bleeding anywhere? All right, now I gotta go back and talk to the patient, right? Have you been bleeding anywhere? You check her bottom, you see if she's bleeding out of her bottom. It's the most common place, right? You check and see if she's on blood thinners, even though you think you checked that already. Okay, no, it doesn't seem like she's bleeding anywhere, obvious. You ask the family about trauma, sometimes you'll find out like, oh, they fell and they've been complaining of back pain. And then you scan their back and you find that they have like 2 liters of blood in their retroperitoneum because they had a retroperitoneal hematoma. And everybody just thought Granny was complaining about her back pain she's always complaining about. So you ask about those things, right? Okay, no trauma, no. Okay, all right. Hemoglobin's okay. All right, I'm moving on. Okay, hemoglobin's low. I'm thinking like, whoa, hold on. Why does she have a low hemoglobin? Does she have anemia? Is there another possible cause of shock here? All right, and then obstructive shock, we get the chest x-ray. She doesn't have a pneumothorax, and pulmonary embolisms are pretty rare. Well, actually, I should not say that. I'm getting told by Sarah. They are not rare, but in her, I think I have another good explanation, right? This infection thing seems like it's really plausible. And so I'm going to go with that for a little bit. If this doesn't end up working out, doesn't end up making sense, then maybe I'll kind of come back to the drawing board and think about some like other things. But people with PEs also usually have like low oxygen, a big enough pulmonary embolism. If you have a big enough pulmonary embolism to give you obstructive shock, you usually have significant difficulty breathing and some hypoxia and some shortness of breath. And she's not complaining of any of those things. Now, can I say it for 100%? Are there people that would say, Nicole, no, I saw a patient with a PE once and she had the exact same story and the UTI was a red herring, and totally possible, right? But I've thought about it. I'm going to come back to that if this UTI stuff doesn't start to make some more sense, okay? If my resuscitation doesn't work, right? So I'm going to go ahead and I'm going to treat this. So what's the treatment for septic shock, or what's the treatment for sepsis? So there is Surviving Sepsis campaign. It was a big study. You give them a bunch of fluid, okay? Kind of want to be careful in people who have heart failure because giving them a bunch of fluid can cause them to go into volume overload. So that's sort of a caveat, but forget I said that. You give them a bunch of fluid, you give them broad spectrum antibiotics, and you get infection source control. What does that mean? Someone has an abscess, you drain it, right? If somebody has a collection of pus, so like an empyema in their lung, you drain it. If someone has a surgical cause, or sorry, if they have appendicitis, if they have a gallbladder that's blocked and infected, like cholecystitis, you take care of that problem, right? You cut it out or you put a tube in it with interventional radiology. Someone is having urinary tract infection, you want to make sure that that is an area that is getting drained. So older folks sometimes have urinary retention, and even people that are younger, like, will say, I just feel like I got to run to the bathroom. Like, I feel like I can't get out all the pee. And so people will have urinary retention sometimes that goes along with a UTI. This lady is a little bit older, right? She is a little bit altered. She's a little bit confused. So do I know if she's emptying her bladder? We need to know this, right? Because if she's not emptying her bladder, that's like equivalent to like just leaving that abscess undrained, right? The infectious material is just sitting inside her body with all of these blood vessels around, just waiting to soak up that bacteria and make her even more sick. So put an ultrasound on her bladder and you see if it's full or not. So with this patient, we put an ultrasound on her bladder. It looked like she had about 300 cc's in there. We drain it, put a Foley catheter in, and that thing stays in until she is more awake, alert, till this infection is cleared. Then we can take it out and make sure she can pee on her own. But the risk of keeping all that infectious material in her body, not worth it right now. And if somebody's blood pressure remains low despite IV fluid resuscitation, you start vasopressors. So there's medications that there's norepinephrine, which is the most common, called that Levophed. You can give them epinephrine, you can give them vasopressin or phenylephrine. But those medications are for, if you just feel like you can't give them any more fluids because of other reasons, or they're still having so much of that vasodilatation and capillary leak that you need that norepinephrine to help it squeeze down so that the patient can maintain their blood pressure. Okay, so say we do this. We give her some IV fluids, we start broad spectrum antibiotics, and her fever gets a little better, her heart rate gets a little lower, blood pressure is still kind of low, but it's starting to get the 80s, 90s. Okay. So how do we know if what we're doing is working? Right? You're making a lot of guesses, not guesses, but like you've created an idea of what the pathophysiology is in your mind from the information that you have. Okay. How do we know if we are resuscitating people correctly? So you look at how these things trend, right? Is their blood pressure coming up? Is their heart rate going down? The reason why their heart rate's so high is because their blood pressure is so low, right? The problem is the blood pressure, and the heart rate is like, okay, come on, guys, we got to go. Let's get this blood where we got to go, right? So if the blood pressure comes up, then the heart rate can kind of chill out and come down. Look at their urine output. So I put this picture up here is because think about all these like different glasses, right? And all the levels that they're at. When you start to fill up the glass and it's full, it will start to overflow. So I think about this when I think about my patients who are hypotensive or in shock. All this stuff that we're doing, we're trying to find out what their volume status is. Are they hypotensive because they have no volume and they're like on the left side of the glass with almost no water in it? Or are they the one that's like second to the right where they just need a little fluid? So urine output really helps because your body will naturally is not going to start peeing until the tank is full enough, right? when people are dehydrated, they don't pee because your body is like, no, thank you. I need this water. I don't have enough to start peeing out again, right? And so if a patient, we don't know how many liters down they are, right? We do all these things to guess, right? We look at their heart rate and their blood pressure. Sometimes we look at like to see how big their IVC is. And sometimes that's a surrogate of how much volume they have or how dehydrated they are. So if you've given them 3 liters and they haven't peed a lick, then that tells you like, oh, wow, this was like bad. This is some bad shock. Now you want to check their bladder, make sure that they don't just have a urinary obstruction and can't pee. Versus, if you do give them a bunch of fluid and they are peeing, then you're like, okay, I've reached the top of the glass. We're now starting to we have enough fluid that the body is willing to pee it out. So look at their urine output. You look at their lactic acid, right? If you start giving them more fluid and more of the stuff that the body needs, then they'll stop using this inefficient anaerobic respiration and they'll start back at the regular kind of respiration, right? Less lactic acid, okay? If the creatinine starts to go in the right direction, starts to come down, that tells us, okay, the kidneys are seeing some more blood, they're getting what they need, and they're starting to clear this creatinine. Check their pulses. Are they pulses stronger? Are they warm? Are they cold? And then particularly for this patient, their mental status. You have all of these things that go into your picture of the patient and all of these things that go into how you see if you're being successful or not. So 2 hours later, your blood pressure is 100/70, better. Heart rate's 105. We're not there yet, but we're much better. Respiratory rate's 18 and temperature came down. We put a Foley catheter in because she was retaining. She's now a little bit perkier, a little more color to her face. She's more oriented. She knows where she is now. She's able to give you a little bit more of a history. She pees out 1 liter after you give her 30 cc's per kg. So we're not there yet. Still need to keep giving her some fluid. But we're kind of I'm kind of out of the woods, I think. So there you go, back to your assignment. And then you got to figure out where to go next. So you look back at your to-do list and you start going down the room. You eyeball the patient in room 1 and say, hi, Mrs. Seltzer. Yes, I'm going to write you for your oxycodone. Are you still having chest pain? No? Okay. All right. Looks like we're waiting for a medicine bed for you. All right. You probably get a stress test in the morning. Okay. You let us know if that chest pain comes back. Room 2, we already talked about that one. Room 3, you go in and see this young woman, and she's still a little tremulous. You ask the nurse when you gave her Valium, and she says, oh, I just gave it to her. And you say, okay, I think we need to do a double dose this time to kind of get ahead of this. I'm worried we're going in the wrong direction. Why don't you give her 20 of Valium instead of the 10? You write for that. You tell the nurse, let me know if this doesn't work in an hour. And then you go to have this conversation with this family about the miscarriage. You either get the phone interpreter, which is less than ideal, or you get the in-person Spanish interpreter who sometimes is available, and you tell her that she's having a miscarriage. You tell her it's the most likely thing because we don't see any evidence of a pregnancy on the ultrasound and you have been bleeding for 2 days. But we need you to come back and get a repeat pregnancy hormone level so we make sure the pregnancy hormone level goes down, because sometimes people can have an ectopic pregnancy instead of a regular pregnancy, and in which case that would cause the pregnancy hormone level to go up. They're appropriately sad. You have your whole spiel and you move on to the next patient. You ask case management to try to arrange for them to get follow-up because they're Spanish speaking and uninsured, and there are special programs for that, but they're not necessarily easy to get into. And then you go to room 5, you see her glucose has come down pretty well. And you think you can discharge her on some outpatient medications if we can get her a good discharge plan. And then you look at your watch and it's 10 p.m. And you hear tier 2 in 5 minutes and you are back to the races. So that is the first couple hours of an ER shift in Baltimore sometimes. So I made this talk a couple days ago, and then I had like 3 patients that were in shock today, and I was like, I could just talk about all of these patients. But here's my information. And you guys can ask me whatever you want, and I will try to answer it.
Absolutely. Well, first of all, thank you so much, Nicole. This was a really, really informative session we had here. We have a lot of pre-PA students, a really growing presence of pre-PA students out there, and we do have some pre-med students and other pre-health students who always join us for really all these sessions. But a lot of students loved how engaging this was in terms of going through the patient case, hearing about these scenarios. We do have a few questions, and for those who might have a few questions, feel free to type them in as we go. You can really type in questions at any time, not just at the beginning, anytime. The first one we have is from a student asking about these scenarios, saying, how long would you have wanted, ideally, to stay with room 2? And during the time that you were waiting to see the condition improve, would you look into the other rooms?
Yeah. So for like simplicity's sake, I didn't want to make it too complicated, but yeah. So I, would probably have written all of those orders, and in like in those 2 hours would have been able to see and dispose some of those people. We also are during that time also, so you have like trauma patients that come in at different times, and that's totally sporadic. As opposed to like your assignment. So you have like your assigned rooms, and those patients, like when one leaves, one comes, one leaves, one comes kind of thing. But so yes, I would have.
All right, our next question is, what aspect of emergency medicine as a specialty do you like most, and what aspect do you dislike most, if there are any?
So what I like most is like solving problems. I think that it's gratifying. Now you have to like redefine what solving problems is. A lot of people when you go into medicine, you think you're going to be able to like heal everybody. And you learn kind of quickly what's in your control and what's not. One of the keys, in my opinion, to preventing burnout is trying to figure out what is yours, what's in your wheelhouse to change. So that can be tough in medicine, realizing that you can't change everything. But I like the unpredictability about it. I like certainly it becomes more predictable. I've been doing it 7 years, so like there's a lot more predictability to it, and maybe it won't feel this way in 15, but you get to solve problems. You get to use a lot of different areas of your training and your brain. And it's dynamic. You're walking around, you interact with people all the time, all day long. And I think the culture of emergency medicine is kind of cool. I think it's very teamwork based. When I worked in neurosurgery, there's a lot of passive aggressive stuff that would happen as far as like writing orders and pages and things like that. Well, you can't really afford to be mad at people when you're in the ER because you sit next to each other. You're sort of like in the foxhole together. So from a PA perspective, one of the reasons I did switch was because I felt like so in neurosurgery, the knowledge and ability gap between an attending and an APP is probably one of the widest in all specialties. Didn't matter how much I tried and studied, I was never going to do that brain surgery on my own, and also there's a lot of ego on this side, and there's a lot in that culture that would prevent me from growing, at least where I was working. Okay. Now, that sort of disincentivized me a little bit. Like it's easy to kind of check out when not as much, when you don't have you don't have that much to look forward to. In emergency medicine, don't get me wrong, what the ED doctors do, their training, it's not easy, okay? But I feel like as a PA, if I work my butt off, there's nothing in that emergency department that I couldn't do that my attendings do. Now, do I need to have supervision? Does there need to be a doctor there? Am I saying PAs can practice independently? I'm not, right? But like that motivates me, right? I intubate people. I do central lines. Like I want to be able to deal with the sickest patient ever that comes in. Am I able to do that 100% of the time now? No. Am I able to deal with 95%, 98% of what comes in? Yes. But that 5% motivates me, right? And that keeps me on my toes and it keeps me learning. Those are some things that I like about emergency medicine. Some things I don't like about emergency medicine. We have a really broken healthcare system. And in emergency medicine, you get a front seat and you don't get to hide from it. And it's been extremely difficult, like the past couple of years. There's not enough, the way financially, like the healthcare system is set up in this country, it does not necessarily address the needs of patients who are seeking emergency care. I mean, we have very long wait times sometimes, and having to deal with patients who have been waiting a long time in pain, waiting in a waiting room sucks. And staffing's been hard and people have been leaving and there's a lot of burnout, and kind of being face to face with the challenges that are in our healthcare system is the thing that I like the least about it.
Absolutely. They definitely are there. And like you said, you get a front seat being in emergency medicine. On the same topic, on the same specialty, a student asks, is EM a competitive or difficult specialty to get into as a PA straight after graduation if you haven't already done a residency?
It really depends. It depends where you want to live and what kind of ER you want to work in. So you can get a job out of school in ER if you're willing to work on the minor care side, or you're willing to work in the lower acuity side. If you want to work on the higher acuity side, or if you want to work on both, then it is more competitive. ERs are going to look for people that have experience or who have a residency. Now, there's not enough PA residency trained, emergency medicine PA trained residency out there to make it such that the hospital can demand that they only hire residency grads. So there will always be new grads in emergency medicine. But you might not get the city, you might not get the hospital that you want. I also think that there's a lot of, there's a lot of for-profit emergency medicine groups. And you have to be careful about getting your first job there because sometimes they are extremely focused on RVUs and productivity, and you might not get the mentorship that you need the first couple of years in order to become a safe provider. You might not get adequate supervision. So those are some things to sort of be careful for. Now, I work alongside people at my job who are new grads. New grads actually get hired in my emergency department, and I help train them in the non-residency model. So I hope I'm not giving you too bland of an answer, but I also can kind of only speak to like the areas in the world that in the country that I've lived in as well. And if you're willing to, kind of put in your time, right? Like if you don't want to do residency and you get a job in an ER where, they'll let you do fast track, but, you got to do your time in order to kind of be phased into the more acute side of things, and you're willing to go and put your head down and study and learn and look for opportunities, then you get there. It's just, some people say it's faster to get those experiences through residency.
Question is really about, like, is there a certain personality, or is it a spectrum of personalities that you see in EM? So the student asks, would you say there are any good traits or criteria to keep in mind to help someone know if they might be a good fit for emergency medicine?
It's a really good question. So I know what I look for when it comes to residents, people that we hire. I think if you are an undergrad student asking that question, I don't think that you should assume that you know what specialty you will be good at. Because I don't think that I thought that I would be good at this. Emergency medicine wasn't until my last rotation in PA school, which is one of the reasons why I didn't go straight into it, because I didn't really know I liked it. So, there are people who are, people think, oh, everybody who's in emergency medicine is probably really big personality, really, go-getter. There are some quiet people who work in emergency medicine. And oftentimes they can be a really calming presence, they really keep their cool. They're calm under pressure. So I don't think that there is a required personality. I would say that the way to find out if you think it's your fit is you spend time in that environment. So when you're in med school or PA school, try to get your ER rotation sooner, earlier on in your rotations. And spend some time on a medic or with EMS. I think that the people that I think don't do great in emergency medicine. Now, I don't think that you can know this about yourself until you've been pressed in some form or another, but some people are very linear thinkers. So think about one problem in this way, and you cannot interrupt them. They need to finish this one. That's linear. And then there's non-linear thinking, which is I'm thinking about 3 problems at the same time, right? And so now, can you train yourself to be a non-linear thinker? To some degree, yes. I think about waiting tables is it's actually a question I kind of ask when I interview people, because waiting tables is you have to remember that table 5 needs this, and you have to remember that table 3 needs this, and you got to put these orders in, and you have to be able to juggle those things. Now, if anyone's ever waited tables, you weren't necessarily really good at that on day 1, but if you ended up being a good waiter or waitress, you learned it, right? And there's some people who they can't learn it. I don't want to say can't. They have a really hard time, their brains just really have a hard time doing that. So I think that you need to be able to be flexible, adaptable, you need to be a good team player. And people say you need to be good under pressure. I think that's learned, because I don't think I would have ever described myself that way. And I don't even know if I would even now describe myself that way. I can do it, but I don't think I'm naturally someone who's good under pressure. So, I think that if you are thinking about emergency medicine, and you're thinking oh, I don't know, that sounds really a lot. I don't know if I have that in me. That would be a normal feeling, because most people are really intimidated by the chaos that is the emergency department. And so I just wouldn't sell yourself short until you explore it and spend time there, if that's a specialty that interests you, and see how you respond and see, yeah.
Our next question is one that is more to do so with the actual practice. So if you're willing to speak on this, a student asks about most emergency medicine contracts being 312s, or 3 days for 12-hour shifts, which causes naturally longer stretches of off days. So with that said, do hospitals tend to provide you less PTO time?
Oh, that's a good question. So it depends on how your structure is. So I work for a hospital and I get PTO. So if I want to take 3 days of my PTO and not work that week, then I don't work that week and I use my PTO. It's really different. This is the same thing for emergency medicine physicians is some people are working for groups that are contracted to hospitals, in which case you're just contracted for a certain number of hours, and then you don't get PTO, but you probably get paid more for those hours. So it really depends.
Our next question is from a student asking, what do you believe is the best way to manage the mental stress of ER work? I'm sure that's a tough one.
So like we're all evolving, right? The things that like really challenged me and worried me like in my first couple of years are not necessarily the things that worry me now. I think working in a place where you feel respected, and where you feel like you have room to grow. I think that, I mean, I'm not sitting on some high horse. Like this is like, you know, we all sort of go in waves of burnout, and I don't even know if I love that word. Some people would say moral injury. But you know, one thing that I've thought about recently is, you know, trying to count my wins, and trying to have those things be maybe even small. Because, you know, like particularly on these triage shifts where, you know, you're working in the waiting room and there's these crazy wait times and you're like basically doing waiting room medicine, you know, like it's a lot, it's an onslaught of a lot of people complaining for very good reasons. And, you know, I try to say like, okay, what patient did I help today? Okay, I made that person feel better. Okay. Like me and that nurse, we had like a really funny joke about this. Like, you know, this person who was really scared and they didn't really understand what was going on with them and their diagnosis, I was able to help them understand that. And so those things have kind of helped me. You know, I think like the one thing about emergency medicine that people used to, oh, it's just, you just clock in, clock out, you clock out and you're gone, right? And so as opposed to some specialties, you know, that patient that's maybe a little difficult in your clinic is still your patient. You know, they still can email you. They're still going to come and make an appointment. Now we have frequent flyers in the emergency room, but you know, there's pros and cons that comes to be both of those things. So when I'm off, now it's a little bit different for me because I have some like other responsibilities in the department, but you know, for most people, if they're off, they've clocked out, that patient is no more their problem, right? And so they have signed that patient out, their name is off the chart. And so that is helpful to sort of be able to turn it off, as opposed to some other specialties where there's a lot more kind of chronicity management. I'm talking a little bit all over the place. I hope I gave you some ideas, but it's a process. I think that a lot of people will say like, oh, I can never do what you do. And like, maybe they're right? I don't know them, right? Maybe they're the type of person who could never hack it, right? But you really don't know until you expose yourself to it. Because I can tell you that I never thought I would be able to hack this. I did not, you know, I didn't like think of myself as, sounds very philosophical, but I didn't think I was as capable, you know? And like, I didn't think that you could be trained to do the things that I do now. Like if you would have told 18-year-old me this kind of stuff, you know? And so, you know, I think you have to try. And that's what, like, you know, I say, like, when you're in PA school, when you're in medical school, like, try, just keep an open mind. Try to see how you feel on rotations and what excites you and what doesn't. Sometimes things that scare you, like, also excite you at the same time, right? And so, you know, are there people that like come to emergency medicine because they're like, this is so cool, this is so exciting, and then they find out quickly, like, this is so not my thing. Like, this is exciting on TV, not in real life, right? This is too much. I don't want to do this. I want to work in the outpatient world, right? That's going to happen. But you really, if you haven't been exposed to those things, you just don't know. Human beings can be trained to do a lot of things. And that's like one thing that I've really learned in medicine is like people can be trained and can figure out how to like manage really tough things, and they can do it every day, and under the right circumstances.
Yeah, there's definitely a learning curve to that part of things. A few more questions before we wrap up. The first one is about the ratio of trauma versus other medical cases that you see in the ER.
So trauma is a very big category. Trauma can be anything from a small fender bender to granny fell down to someone got shot 5 times. So we work at a level 2 trauma center. I don't know how many traumas we get a day. There's certain like criteria for what we consider like a level 1 versus a level 2 versus a level 3 trauma. So I can tell you like today, I probably took care of 3 trauma patients. And those were, one of them was a really bad motorcycle accident where the guy was unconscious and he needed to be intubated. And then then 2 of them were smaller scale motorcycle, or one of them was two other car accidents. What was I saying? So it's more medical, and like trauma is on television and stuff, but it's not the majority of what's in the emergency department. Gunshots are rare, and I hope they stay that way, and they're probably not rare enough. But also with the trauma cases, you co-manage the patient with the trauma team or the general surgeons for like the gunshot victims and the stabbings and stuff like that.
All right. Our next question is about your responsibilities outside of practice. So specifically your administrative and educational responsibilities. Are those part of the job, or are those things that you just take out of interest?
So they're part of my job now. Originally, like I started the PA onboarding program and created a curriculum for that. And that was kind of like an interest of mine. And they gave me a couple extra hours of pay to run that program. That wasn't the residency program. And then I got the position as the assistant program director, as well as the PA onboarding coordinator. So they are part of my job. So I am contracted for 36 hours a week. 24 of those hours are clinical time. And then 12 of those hours are education time. So that's time I'm spending doing the education stuff. I used to have only 1 day every 2 weeks that was for education stuff. It's increased to 2 because we've had some like staffing changes. It may eventually get cut back down again to 1. But that's something that I do, like, it's not like I do it in a whole 12-hour block. So I'm answering emails throughout the week. We have like, I am running a sim session tomorrow. We have like every Friday morning, we have conference. So it's sort of spattered in throughout the week. But some of it, like I can do from home. I don't have to be in the office. So that's kind of nice.
Right. And I think we'll wrap up with one more question. With you being part of the process with recruiting PA students to your residency program as program director, I wanted to ask, what do you specifically look for in students when you are going through interviews? Are there any, being in Johns Hopkins, are there any specific interests that the program has for, like, let's say research or things like that, that are not necessarily going to be on a broader scope sought after at the same extent from other programs? Are there specific interests that Johns Hopkins has with applicants?
So I think that we look for a lot of similar things to what other emergency medicine PA residencies look for. If you have research, great. It's not a huge focus of our program, although we would welcome it if people wanted to make it a bigger part of the program. So what are we looking for in residents? So I think we're looking for kind of a lot of the things I talked about, like people that are good team players, easy to work with, who are adaptable, who are motivated, who can have like an attention to detail when necessary, right? Like, you don't always have to, like, there's the cowboy aspect to emergency medicine, but then there's also like, if you have to focus on details, like those details are important. People that are good at multitasking, people that are energetic, I think I'm kind of repeating myself here. I think people that are familiar with emergency medicine and really want it, like I didn't mention this, but you work your butt off, like in this program, you work like 50 to 70 hour weeks, like, and didactics, and you go to conference, and you go to work nights for, 18 months. And yes, that's what the physicians do, for their training, but you don't have to do it as a PA resident, right? So I think we're looking for people that are really like up for that challenge and are ready for it. Who are ready to be a part of their own education. Some people have a hard time like transitioning from school to work, right? And sometimes people think, oh, like I'm in a residency training program, so you'll continue to spoon feed me. Like, no, like you have to sort of you have to also be the one that's sort of advocating for yourself and your own learning opportunities, and taking advantage of the mentorship and the opportunities that are there. So I feel like I'm rambling, and if I am, it's because I have been up since 6 o'clock and I did a 12-hour shift today. So you're going on like hour 14 of me talking. So forgive me if this is not good.
We can't blame you there. We can't blame you there. But thank you so much for gathering this together. To the students listening in, please post your thank yous in for Nicole in the chat. This was such a great session. We love how it was so engaged with the scenarios. It really gave us a walkthrough of what you're going to see in the emergency room, which was fantastic. So again, thank you so much, Nicole. I have a few reminders before we wrap up for today's session. To those who are just listening in, if you'd like to earn credit for your attendance today, you must pass the quiz to receive a certificate. That quiz is now posted in 2 places. It's in the chat box, and it's also on our website under the virtual shadowing page. It will be due at 11:59 p.m. Central Standard Time this upcoming Wednesday next week on September 7th. So keep track of that deadline if you'd like to earn credit for your attendance. And in order to pass, you must have 6 out of the 10 or 60% as your minimum passing score. Once you do pass, your certificate will be sent to the inbox of the email address that you list on the quiz. And just in case you don't happen to get it in your inbox, please check your spam folder. And in case it's not there too, feel free to shoot us an email and we'll help retrieve your certificate for you. For our next shadowing session, be sure to catch us with Dr. Daltani for a shadowing session over periodontology and implantology. This one's going to be for our pre-dental students, but if you happen to be interested in joining in, feel free. We're always happy to have really any students join us. And we do have quite a few students from different fields joining us in for different specialties. So that's great to see. Like I said earlier at the beginning, we operate on a Monday and Thursday schedule, usually at 7 p.m. Central, but just to stay tuned with us, feel free to follow us on Instagram or subscribe to our listserv where you can hear more about not only shadowing, but our other programs. We actually launched 3 more programs, a mentorship program and 2 other community service programs that you can get yourself involved in. Their application cycles have closed, but if you're interested in applying for the next semester in the spring, be sure to keep tabs on that. The applications will be released soon, later in November of this year. But I think that's all that we have to say. And like Nicole has here, feel free to reach out to her for any questions. Thank you again so much, Nicole, for sharing this. It's really great that students can go ahead and contact you outside of the session for any questions that they have. We really, really appreciate that. And yeah, are there any last words that you want to shout out for students? Any last pieces of advice?
Nothing comes to mind, but you know, I think if you are, I don't know if everybody in the session's pre-PA or pre-med, or people are kind of like figuring out what they want to do. I think, you know, looking at what kind of specialties you want to do, I think more information is always good. So, you know, talking to people that are in various different types of fields that are PAs, doctors that are in different fields and different people's experiences, shadowing when you can in real life, I think was something that was extremely helpful to me, to help me figure out where kind of my place was. So that would be my advice.
Yeah. All right. Well, thank you again for everyone who joined in. And like I said at the beginning, if you have any questions that you're just wondering about Hearts for Health in general, feel free to reach out to us over email at shadowing.h, the number 4h at gmail.com. Just want to let everyone know, because I know that there were a few questions we received during today's session. So if you have any others, feel free to reach out. But yeah.